Hello, everyone. Warm greetings from APAAACI, the Asia Pacific Association of Allergy, Asthma, and Clinical Immunology. Today, we have a very important webinar on COVID-19, the pandemic, and allergies and epidemic, the known and the unknown. We have with us several experts from our region who will be speaking on the different aspects. I will give an introductory talk on the immunology and infection. I'm Ruby Pawankar, the president of APAACI. Professor Jiao Wang, who is the president-elect of the organization, will be talking about COVID and asthma, lucky or unlucky. This will be followed by Professor Maricia Recto, the president of the Philippine Society of Allergy, Asthma, and Immunology, on life-threatening ARDS or the cytokine release syndrome. And after that will be the talk on immunomodulation to severe COVID-19. Do we wait for RCT? This will be given by Professor Bernard Thong, who is our board member of APAACI, as well as the editor of the web. And the final talk will be given by Professor Amir Latif, our second vice president of APAACI, who will be talking on dealing with immune deficiencies in a pandemic. I'd like to give a brief introduction on this webinar. As you know, that the outbreak of this new type of novel coronavirus, COVID-19, by the SARS-CoV-2 was reported in Wuhan, China in December 2019. And since then, it spread rapidly to over 180 countries, today 211 countries around the globe. And the disease is caused by human transmission of the severe acute respiratory coronavirus 2 or SARS-CoV-2. The World Health Organization has declared it a pandemic, and while many countries have been following different manners of struggling with this disease or taking care of controlling this disease, they have managed it well in some parts of the world through strict lockdowns and strict measures, which we will talk about a strict strategy. So, like Tomas Peuyo says, the hammer and the dance strategy to tackle COVID-19 has brought him millions of readers from around the world. Many aspects of COVID-19 pandemic can be described as a hammer and dance. Not just the lockdown followed by safe opening of the economies with the inadvertent risk of new community clusters, then making it a greater challenge as we see in Beijing. But at the same time, we see many countries like Australia, like Singapore, like Thailand, Vietnam, New Zealand, and Taiwan, where the control has been really good. And we will discuss that in our presentation today amongst the various scientific aspects of this COVID-19. In this approximately 75 to 90-minute webinar, we will take you through various immunological aspects of this pandemic, both from the acute viral infection aspect to the impact of two important disorders, that is allergic airway diseases, asthma and rhinitis, the cytokine storm, and then talking about the immunomodulation and therapies, as well as the immune deficiencies in both children and adults. We hope that in the next 12 to 24 months, a hammer for the COVID-19 through a COVID-19 vaccine will one day nail down and put an end to this devastating pandemic. So with this, I would like to start the first talk. And the first talk is by myself. And the topic of my presentation is Immunology of COVID-19 Infection, the Hammer or the Dance. What is COVID-19? COVID-19 is an infectious disease caused by the most recently discovered coronavirus. And this new virus, as I mentioned before, was first detected in Wuhan, China in December 2019. Subsequently, the World Health Organization designated it as an ongoing pandemic as it started spreading in the region of Asia Pacific. This COVID-19 is caused by the severe acute respiratory CoV-2, SARS-CoV-2 virus strain, and it's therefore called COVID-19. Now, when we talk about the coronaviruses from SARS to MERS to COVID-19, I'd just like to take you through the slide and just focus on some of the similarities and some of the differences. SARS-CoV-1, which occurred between November 2002 to July 2003, was known as a classical SARS-CoV. The genus was beta-CoVs, lineage B. The possible natural reservoir was the bat, and started off in China in Guangdong province. And the total number of people who were affected by it were about a little over 8,000. The mortality rate was about 11%, and the transmission pattern was from animal to human and then to human. Whereas MERS-CoV took place between 2011 to 2018. It's again beta-CoV lineage C. The possible natural reservoir was the bat, and of course the intermediary was the camel. This was reported in or happened in the Arabian Peninsula, caused about deaths ranging up to 800, but the mortality rates were about 37%, and it was more regional, unlike SARS-CoV-1, which was global. The receptor for SARS-CoV-1 was ACE2 receptor. That for MERS is DPP4. Now coming to SARS-CoV-2, which started in 2019 and is continuing today as a major pandemic globally, is also beta-CoV lineage C. The natural reservoir is again the bat, and the intermediary is considered possibly as the pangolin. Started in Wuhan, as of today, there are over 2 million number of cases and over 190,000 deaths. The mortality rate ranges from 1 to 9%, and is again transmitted from animal to humans, but then very much from human to human. The interesting part here is that the receptor for SARS-CoV-2 is same as SARS-CoV-1 and is the ACE2 receptor. Now, trying to understand a little bit about SARS-CoV-2 or COVID-19 virus, I'd just like to highlight what are the things that this virus actually does to the host cell. So the different proteins, like the viral proteins, the S protein or the spike protein, as you can see here, it is attaches itself to the host cell, and then it leads to certain cytotoxic effects, and it causes degeneration of the infected cell. The E or the envelope protein then acts by causing cell stress and apoptosis, and response for the especially for the respiratory tract pathology. So mainly attacks the respiratory tract. The M protein then acts by inhibiting the interferon, uh, the type 1 interferon. And the type 1 interferon is crucial in trying to inhibit viral replication. So the M protein actually inhibits that. And then the N protein, or the nuclear protein, then inhibits again type 1 interferon and stimulates apoptosis. Now, when we look at the COVID-19 pandemic by country and territory, it's very interesting to see that the spread of this pandemic is nothing like the other two that have happened recently, the SARS-CoV-1 or the MERS, but is more similar to the Spanish flu that happened several years back, affecting many countries. So as of date, there are 213 countries and territories that are affected around the world. And as you can see, the darker the color, the more intensity is, or the maximum number of cases and mortality is shown by the intensity of the color. So totally, you can see here the number of cases, the number of deaths, and those recovered. Just to highlight a little bit about Japan. So in Japan, this is a report of March 9th, when actually it started going up. The peak was in April. And most of the cases, though it initially started from the cruise ship, the Diamond Princess ship, which had patients who were positive to COVID-19, but then it spread within on land through these clusters that you can see: the Niigata City cluster, the Osaka Live Music Venue cluster, the Arida City cluster, the Aichi Sports Club cluster, day service facilities, and then also there were also some hospital infections, but many of them actually came from different live music venues or gyms. Now, this famous writing by Thomas Peuyo on the coronavirus, The Hammer and the Dance, has been so widely read by people all over the world. And he shows this kind of graph in his theory is what will happen to COVID-19 based on the actions we take. So if we do nothing, or if there's mitigation, the number of cases will increase, and the number of deaths will increase. If we have a hammer, which is like a strict lockdown, there will be an initial peak, but then it will flatten down, and it will cause a reduction in the number of infections and deaths. The dance is when you kind of start reopening it, or slowly releasing the lockdown in a very, very calculated manner, with observation, to ensure that there isn't a second peak that occurs due to the opening up of the lockdown. So when we look at what he tries to explain in his own words, he says strong coronavirus measures today should only last a few weeks, and then there shouldn't be a big peak afterwards, and it can be done for a reasonable cost to society, saving millions of lives along the way. So if we don't take these measures, this will result in tens of millions of infected patients. Many will die, and along with this will be a big burden, because it will require intensive care and a big burden on the healthcare system, which will then collapse. And within a week, countries around the world have gone from this coronavirus thing is not a big deal attitude to declaring the state of emergency. And yet many countries are still not doing much. Why is it so? So every country is asking the same question: how should we respond? What should we do? And there is confusion and instability in strategies, and people are going back and forth. I mean, for example, in Japan, we had semi-lockdown, which, and with all the different measures that we took, things were coming down. But in the last few days, the numbers have increased just in Tokyo from a low number of 19 to 20 to 55, and today it's actually reached 100. And some countries like France, Spain, or Philippines have since then ordered heavy lockdowns, whereas other countries like US, UK, or the Switzerland have dragged their feet, hesitatingly venturing into social distancing measures. Now, looking at Japan, this is the typical picture I showed you, that what happened on March when the clusters occurred. And then the peak was around April 17th or so. And then they had this semi-lockdown with closure of the schools were closed well in advance, and so were also different hand hygiene measures, wearing of face masks, and social distancing is in a way practiced in the Japanese culture itself to some extent. But yes, there were closures of department stores and such measures done early, and that caused lowering of the peak, and the numbers had really come down. And then things have reopened, and we are now in an open state, the third state of our reopening, but again, that's being done gradually. And these measures have been done successfully in many countries, like in Taiwan, it's been one of the most successful situations. In Singapore, except for the dormitories, the basic strategy has been very successful. In South Korea, the extensive amount of testing has really been very successful. Thailand has been successful. So many of the Asian countries have really been successful. On the other hand, there are countries like Pakistan, which has a huge number of cases now. India, after its very strict lockdown or the hammer, is now in a state of real calamity with having huge number of cases increasing. And in Philippines, I think the lockdown is just gradually getting opened up. So that a gradual opening up is very important to be able to control the disease. Now, when you talk about the immunology and the infections, let's just briefly talk about innate immunity, the immune response. So you have the different cytokines, which actually have different functions. For example, the interferon alpha and beta, they control viral infection. IL-1, TNF alpha, and some chemokines actually mediate local inflammation. IL-15 and IL-12 stimulate proliferation and activation of the NK cells. Interferon gamma is actually important in the activation of the macrophage. IL-10 and TGF-beta limits and controls local inflammation. And interleukin-6 increases the production of neutrophils in the bone marrow. What about adaptive immunity, or this second phase of the immune response? There are four characteristics of adaptive immunity. There is antigen specificity, there's immunological memory, there's diversity, and there's the ability to distinguish between self and non-self. And this response involves lymphocytes, B cells, and T cells, the antigen presenting cells, which can be basically either macrophages, B cells, or immature dendritic cells, or a combination of these. And in the induction of the T cell responses by the respiratory virus, as you can see here, the virus actually enters the human body through the epithelial cell, through the barrier, opening up the barrier, and then it's taken up by the dendritic cells. The dendritic cells then take up the virus and present it to T cells in the draining lymph nodes, and then the naive T cells then become effector T cells, and that results in the initiation of the inflammatory response. So the T cells in the acute phase of SARS in humans actually cause apoptosis due to exuberant TNF interferon response, and high levels of glucocorticoids are released, resulting from a normal stress response. There's impaired CD4 and CD8 T cell activation, altered antigen presenting function, impaired dendritic cell migration, reduced priming of T cells, fewer number of virus specific T cells in the lungs, marked leukopenia and severe lymphopenia, with CD4 positive cells being more than CD8 positive cells. The viral clearance depends on the virus specific CD4 and CD8 positive cells, T cells, and the delayed development of the adaptive immune response and prolonged virus in the body. And then there is the neuroinflammation. And this neuroinflammation, TNF alpha upregulates the adhesion molecule ICAM1 on endothelial cells, and this causes infiltration of monocytes into the central nervous system. The MMP matrix metalloprotease 9 increases the blood-brain barrier permeability. And then there is the CNS aberrant neuroinflammatory loop, where cells producing TNF alpha can damage the neurons and the oligodendroglia. The microglia then produce CCL5, CXCL10, CXCL11, and pro-inflammatory cytokines IL-1 beta, IL-6, TNF alpha. And the astrocytes can then produce CXCL2, CCL5, CXCL12, which results in more leukocytosis. And what happens in as the pathology or pathogenesis in the human host? There is intranasal infection. So basically the ciliated epithelium of the nasal mucosa with apical budding. There is olfactory nerve endings being infected and neuronal retrograde spread. The virus passes to the mitral cells to gain access to the olfactory bulb and eventually the hippocampus. And there is direct infection of the endothelial cells of the microthrombi and hematogenous. And then via the ACE2 receptors, it affects the human respiratory epithelium, the vascular endothelium, the kidneys or renal tissue, the cardiovascular tissue, the small intestinal epithelium, and the testes. So clinically, you can see that the COVID has both systemic and respiratory disorders or manifestations. So manifestations like fever, cough, fatigue, sputum production, and headache, hemoptysis, acute cardiac injury, hypoxemia, dyspnea, lymphopenia, diarrhea, rhinorrhea, sneezing, sore throat, pneumonia, and ground glass opacities, are anemia, acute respiratory, and ARDS. Now, what exactly happens as a proposed host immune response during the SARS-CoV-2 infection? So the aerosolized virus is taken up, the SARS-CoV-2 is taken up, and there is infection of the ACE2 expressing cells. So the virus infects the ACE2 expressing epithelial cells. Then the virus dampens antiviral interferon gamma responses, and this results in uncontrolled viral replication. Then there is an influx of neutrophils and monocytes and macrophages, hyperproduction of cytokines and the cytokine storm, with specific Th1, Th17 activation and inflammatory responses involving the B cells and plasma cells. And this particular aspect of the cytokine storm and ARDS will be addressed in detail by Professor Recto in her talk. And the potential immune evasion mechanism shared by SARS-CoV-1, MERS-CoV, and SARS-CoV-2 are basically the interference with the RNA sensing, signaling pathway of type 1 interferon production, STAT1-2 activation downstream of interferon, and this leads to immune exhaustion and immune suppression. So what about the emergence of the immune responses during non-severe symptomatic COVID-19? And this was a paper published by Irani T in Nature Medicine. And you can see on the left side, there is a recruitment of immune cell populations in the activated CD4 and CD positive T cells in the patient's blood before the resolution of symptoms. And you can see the time course of it. You can see that the CD8 positive cells peak from the 7th to the 9th day, and CD4 positive cells also go up, but the CD8 positive cells, as you can see, are more in the population of CD38 positive HLA-DR positive cells. And then they go down by day 20. On the right-hand side, you can see actually the viral load, and a higher CT value means low viral load. So the viral load actually increases by day 7 and stays on till day 10. And it's mainly detected in the nasopharyngeal swab, in the sputum, and in the feces, but not detected in rectal swabs, urine, or whole blood, or the throat swab. Now we look at the clinical presentations of COVID-19. As I already mentioned in my earlier slide 2, there could be asymptomatic infection, but then there could be mild without pneumonia. There could be negative RT-PCR but positive antibodies. There could be positive RT-PCR after recovery because of the presence of viral fragments, but not really being necessarily infective. Then pneumonia with mild symptoms. There could be an onset of diarrhea and pneumonia with pre-existing COPD, pneumonia with urticaria or other cutaneous manifestations like atopic dermatitis, or it can be complicated with secondary bacterial pneumonia or sometimes pneumonia with allergic rhinitis. But here I'd like to just highlight the clinical characteristics of 140 patients that were infected by SARS-CoV-2 in Wuhan. And in this study, they just look at the different manifestation, but they also look at the comorbidities. And here I'm trying to highlight the portion that's actually within the red triangle, red square, which says because the comorbidities are classified as common, less common, and not reported at all. So when you see the common ones are hypertension, diabetes mellitus, and then of course the less common COPD, urticaria, and active smoking, but not reported at all in this study. They talk about asthma, allergic rhinitis, atopic dermatitis, and food allergy. So basically asthma and allergic diseases. And this is what Professor Wang will talk about in his talk. That will be followed by after my talk. And he will highlight actually this particular aspect of the relationship of COVID-19 with asthma. And when you look at the different risk factors of COVID-19, it's very interesting to see in this study that among the 298 confirmed cases, when they looked at the different risk factors, the clinical outcomes were actually if the CRP was higher, it resulted as a risk factor, of course. Other things were comorbidities, were presence of comorbidities like hypertension or diabetes. Age was an important risk factor. The older the age, more likely to have more severe form of disease. CRP being higher, IL-6 being higher, and ESR being higher. So these were the different risk factors they actually outlined in their study. The other interesting thing was this publication, which actually looked at SARS-CoV-2 in children. Although now there are reports of inflammatory type of syndrome in children, which can be very severe, manifesting like Kawasaki disease in some children in the United States. But in general, in contrast to infected adults, most infected children appear to have a milder clinical course, or they may even be asymptomatic totally, which is not uncommon. When we talk about the dynamics of the immune response and preparedness, this is very crucial, as Thomas Peuyo already has said, that what we need to do is the hammer and the dance. So what are the things that we really need to keep in mind? We means not only the medical fraternity, but the governments and the public health officials. So implementation of public health resources optimally, including, of course, PPE and stuff like that, but also masks and implementation of hand hygiene, implementation of social distancing, contact tracing, manufacturing and utilization of well standardized serological tests that can give a high rate of positivity and less false negativity, to determine the immune response, resources with like healthcare, medicines and drugs, cross protection and cross immunity, and to determine the threat of persistent infection, to determine the course and the duration of the pandemic. The post-pandemic preparedness is very important to look at the dynamics of reinfection, because this also has been reported that either the reinfection or the persistence of positive RT-PCR, indicating maybe this is just the viral fragments being present, or maybe it's a reinfection. And the other important thing is, of course, we don't know, for example, the antibodies, even if the antibodies are detected, how long they stay in the human body, how long can they protect one from or give immunity, and is this immunity long lasting or just for a short period. Modeling studies to determine the dynamics of infection are important for eradication, for long-term immunity, and also looking at the duration to the next outbreak. So I'd like to summarize by saying that the highly pathogenic SARS-CoV-2 causes even death in infected patients, causes damage to the lungs, maybe residual fibrosis also, while imbalanced and excessive immune response may cause pneumonia. RT-PCR and CT scans are significant for the diagnosis of SARS-CoV-2, and drugs and vaccines are now in the process of being developed. And this will be addressed by Professor Tong, who will talk about the immunomodulators and the vaccines. And finally, I'd just like to leave this talk by leaving you with key resources that you can always look up, because there are so many myths that surround this disease. And please refer to these recommended sites for the appropriate, correct information on COVID-19. Thank you very much for your kind attention. So I'd like to now call upon our second speaker, Professor Jia Wang. Professor Wang, as I mentioned earlier, is the president-elect of the APAAACI, and he will be talking on a very important topic, COVID and asthma, lucky or unlucky. Professor Wang, please.
Thank you for Professor Pawanka's kind introduction and also organization for this webinar. Well, I'd like to talk about, let me have a first slide. Right. So I believe we in the audience were all allergy, and we have a daily practice with a lot of asthmatic patients. When the pandemic broke out, we were worried about, is it possible that our patient group is the most easily susceptibility to the COVID-19, or even they are more easily to get infected or become more severe when the COVID-19 virus that can impact in our asthmatic patient. So actually, everybody were worried about if the COVID-19 will pose a high risk for people with asthma, but actually, they have found some of the quite interesting clinical finding is that they said even for asthmatic patient, it somewhat is not belong to the most easily to find the highly susceptibility group as compared with the obesity, elder patient, or if they have a cardiovascular disease. So it's very quite interesting how the virus infection is particularly for the respiratory virus infection and the relationship for asthma, particularly for the infection in the asthmatic patient or become a more exacerbation for asthmatic attack. Can I have the next slide? Okay, so in the CDC, in the March, they have an announcement said if the people with a moderate to severe asthma, they have some recommendation. Next slide. So when we see firstly, we just see Professor Pavanka present a slide from the Wuhan that is a very initial clinical report. And it's very interesting and quite shocking and quite surprised that it's the non-reported for the comorbidity. It's all belong to the allergy group or asthma. So you can see that even they have a lot of report published in the JACI from Wuhan. They say asthma is during level comorbidity for COVID-19 positive patient, it's just only 0.9. And then for the other, then gradually the virus, SARS-CoV-2 virus have been spread to the globally. So the other place outside the China reported for the COVID-19 patient from the New York, from the UK, or the other accumulates more than 10,000 COVID-19 patients. And then you can find asthma and also maybe chronic respiratory disorders such as like a COPD. It's all belong to the very small portion, and not in the very high ranking as compared with the cardiovascular and also the obesity patient. So the risk for acquiring for COVID-19 in asthma some participants have suggested that they would depend on the geography, age, or even the other multiple mobility. And the real data is still needed. So you can see from this slide that COVID-19 virus is caused by the SARS-CoV-2, and they bind to the HE2, and therefore HE2 receptor they have been spread to the not just only for the epithelial cell, it also in the cardiovascular like endothelial cell. So they have a lot of not just only for the pulmonary infection, they also have extrapulmonary like a cardiovascular disease and also involved for the kidney, even for the neurological system. So if we consider about the COVID-19, they have to go through the AC2 receptor. And then AC2 receptor, after they're binding to the spike protein of the COVID, about the SARS-CoV-2 virus, then after binding, in our cell, they have a feeling that this is the certain proteins that can break down the spike protein and combine it with the TMP-SS2. This protein then can help the virus get inside into the cell. And inside into the cell, they will gradually break down because SARS-CoV-2 is an RNA virus. They have a lot of RNA, single-strand RNA. They can replicate by the RNA-dependent RNA polymerase and then synthesize for a lot of double-strand RNA, then activate the innate system in our cell, such as they have a binding for the single-strand or double-strand RNA, such as like a toll-like 3 receptor or toll-like 7, 8, and 9. So actually, they will started proliferation. But it's very interesting that for SARS-CoV-2 virus, for the replication in our cell, they will produce a lot of so-called virus-associated fragment. And then this fragment actually can block the, because previously when we have the innate immunity system coming out, they will to help and activate type 1 interferon, such as interferon alpha. But in fact, actually, from the SARS-CoV-2 virus, they have a fragment that can block through several pathways, such as block in the RIG formation, and that RIG formation that is very important for the synthesis for the type 1 interferon alpha. And even after they have synthesized for the type 1 interferon alpha, that combined with our, because this is an autocrine effect, then act on the interferon receptor. And this receptor goes through by the step 1 and step 2, and I have a lot of interferon associated protein that come out. But actually from this pathway, it still can be blocked by the SARS-CoV-2. So in the end, actually for the SARS-CoV-2, they have several immune response. Firstly, if we don't have a very strongly innate immunity that can stop for the proliferation. But if the SARS-CoV-2 break this proliferation and induce a lot of interferon type 1 interferon compound from the plasma dendritic cell, they will recruit a lot of innate immune cell, then have a breakdown and become a cytokine storm. I believe my next speaker will focus on this part. And the other way is that if they go uncontrolled and become a multiple inflammatory cells come out, and particularly type 1 interferon have been blocked by the SARS-CoV-2, they will induce not just only cytokine storm, they also have a lot of virus load and cause a lot of innate cell apoptosis. But how come there were two very interesting clinical observations? One is that it seems like the children is very just only have a very mild symptom as compared to the elder people. And then they have been talking about because maybe the younger one when their body they have the ACE2 function is quite well, so they can block because ACE2 is an angiotensin converted enzyme. When the ACE2 receptor is function very well, even they have been infected by the SARS-CoV-2, they still can block the the inflammatory pathway induced by the virus. So a lot of children will going to have a symptomatic, and the other for the elderly because their ACE2 their angiotensin converting enzyme sometimes the activity is defective. So if they have been activated by the SARS-CoV-2, and so they will live for the inflammatory process coming up. So it's very important. Somewhat is that virus interact with their specific virus receptor that will cause the disease. So we will ask the problem. So if we have seen a lot of asthmatic patients didn't belong to the highly susceptibility risk group, then it's only possible that maybe in the asthmatic patient, because there were a lot of have been type 2 inflammation in their lung, so it's possible that in the type 2 inflammation, they somewhat were downregulated for the ACE2 receptor proliferation or the expression. So one letter to the editor article published in the JACI, the ongoing to have a published in JACI, and I found that if the asthma they have a highly IgE production, so they will found out in this group the ACE2 expression in their epithelial cell was somewhat were lowest, and even for the TMSE2. So you can see that even the and one interesting observation is that if the asthmatic patient have been provoked by the allergen, so you can see the post allergen and provocation, the ACE2 expression will downregulate and more, and then just only on the baseline. So if the asthma have exacerbation for the asthma attack, you can see that you can see the ACE2 expression will downregulate, and then a lot of in the environment they have a lot of type 2 cytokines such as like IL-13, and IL-13 in the nasal epithelial cell or bronchial epithelial cell were higher than the ACE2 expression were lower. So it's very quite interesting that maybe in the asthma somewhat because they have already have a chronic inflammation in their lung, somebody is induce more on the type 2 inflammation, and type 2 inflammation like a type 2 cytokine or even the interferon, somewhat the interferon alpha will also decrease it. So how we explain that? How come they still can somehow they can resist to the SARS-CoV-2? And it's interesting, one of the articles published in the Science have found that actually ACE2 receptor is dependent on interferon alpha. So if the SARS-CoV-2 can downregulate interferon alpha, they somewhat they will become a counterback. And even in the allergy situation, for the IgE, for the type 2 cytokine, they all can have a downregulate for the ACE2. So it's very interesting that for allergy individual, this effect, the Th2 cell dominant type, may be somewhat they will activate and then downregulate for the macrophage to come out. So you can see from this cartoon, and they were going to publish one of the letter to the editor. We're going to publish in Allergy. They will show that virus, particularly for the RNA virus, then go inside into the cell, activate for the 2.7 to 2.8 and 2.9, and then this is somewhat the type 1 interferon will should be big out. But for the IgE, for the allergen reaction, so this will counterback for the total receptor signal. So the interferon production will be decreasing. But still, we cannot explain how come this effect can have a counteract with the SARS-CoV-2 virus. One example, one explanation is that in the asthma patient, allergy patient, ACE2 receptor will definitely downregulate. Okay, so one of the series you can see from the Gary, they have published we're going to publish in the allergy, and they have shown that in the normal patient, you can see that easily in the initial, there was quite mild for the disease, for the virus, very easily to be cleared out by the innate immunity, like a type 1 interferon. So the COVID-19 cause severity is very low. This is the very mild COVID-19 infection occur in the children or very young younger generation. But for the elder, or they have a comorbidity for the cardiovascular or even the DM, the severe in the severe COVID-19 case. So they have excessive for the interferon, type 1 interferon. And then this type 1 interferon sometimes it become a hyperinflammation. But this hyperinflammation, sometimes they cannot have a clear up the virus. So the virus loads also still very high. So this interact together, they will cause the so-called exhausted for our immune system and become a cytokine storm, or even they will become a pancytopenia in the eosinophil field, and the T cell will all going down, and then they'll become a very severity of the COVID-19. And then for in the Th2 high asthma, you can see that interferon production was low, but also the virus titer, even they have a high, the symptom is still keeping very low. So the other one of the benefits still we have to consider, because we have to see if any anti-asthma medication will also propagate for the COVID-19 and to infected in the asthma patient. And I would just only raise one example, is using the biological omalizumab. And for the omalizumab study, you can see that during the so-called virus infected season, before during the September, they have a lot of winter virus for the respiratory virus like rhinovirus or RSV. Somehow, if the biological anti-IgE therapy, they can decrease for the virus-induced asthma. And you can see from the further study published in the JACI and also the Blue Journal, and found that they have received the biological, the peripheral mononuclear cell or plasma dendritic cell, the interferon alpha, because by the biological, they will reverse for the suppress for the Ig production, and then somehow they will counter back, and also there's the plasma dendritic cell that can produce the normal concentration for type 1 interferon alpha. So so they have one of the series, you can see that for the Ig production and then combined with the allergen interaction and become a type 2 inflammation, the interferon alpha will be decreased. And so it's very easy to become virus infected and become virus-induced asthma exacerbation. But if we have a block for the IgE, the interferon alpha can restore for their normal production, and somehow they can have restore their antibodies effect. So at least for using the omalizumab is very somehow is still can increase for the antibodies effect in our asthma. So therefore, one of the theories is that it's any possible that in the type 2 allergen reaction, there have some mechanism that will can be for the antibodies effect. So Professor Pawanka and I have summarized the recent study about the innate immunity and by the SARS-CoV-2 infection. So you can see that they will depend on the ACE2 and the TMPSS2 receptor have highly expressed. So after contact, they will increase for IL-6 and the TNF alpha. And the adaptive immunity, they will also increase for CD8 T cell. And then if they were uncontrolled and regulate, they'll become a cytokine storm and become exhausted. And the macrophage is a more inflammatory phenotype. But for the rhinovirus and also the allergen stimulation for in the asthma, you can see the ACE2 will down-regulate, and the type 1 and type 3 interferon will decrease. And a lot of innate immunity molecules, such like MAB for all surfactant protein, have become higher. Even ILC2 and invariant NK cell. And then this innate immunity molecule, they can counteract for the virus. So so this is maybe some of the benefit from the allergy type 2 inflammation. So and for even for the they already reported for the combination for the ICS and the LABA, or even the cyclocos9, is avasco, they can have some of the decrease for the COVID-19 symptom. So I was thinking, and also it just only suggested maybe there were a hypothesis that type 2 inflammation maybe have a counter back for the SARS-CoV-2. And also this is the trained immunity, that if we increase it for the innate immunity, maybe they also can maybe find out the other pathway for the immunotherapy for the COVID-2 and so COVID-19. So in the end, I will just only use this IAACI suggestion that for the asthma patient during this pandemic period, for the asthma action plan, it should be continued carry out. But some of the like a non-function test have to be postponed. And if patient needed to become a nebulization for their bronchodilator, that was suggested as to use the air chamber. Because if we use the nebulization, then somehow they will cause the more easy to get infected for the other general population. And then for biological, at the present moment, there were no contraindication for the non-COVID-19 patient. But if our patient have been infected for the COVID-19, maybe we should stop the biological. But this is just only suggestion for expert panel. We don't have a lot of clinical evidence to prove that. And finally, I would like to close my talk in here. Thank you for your attention.
Good evening. I was tasked to discuss on the life-threatening condition called the cytokine storm syndrome in the context of COVID-19. So as you've heard the previous talks, that COVID-19 can indeed cause havoc to our immune system. And in patients who have the severe or critical disease, the immune system hyperinflation goes to a different level in the form of what we call the cytokine storm. So looking at the three phases of disease progression in COVID-19, we see here that the early stages of disease can actually present as just a viremic phase. However, in a certain percentage of patients who have COVID-19, the main pathology involves a host inflammatory response that can be localized in certain areas like the lungs or it can become systemic in the form of hyperinflammation that can affect multiple organs and cause possible adverse effects as death. So reviewing our adaptive and innate immune responses against viruses, we see a synergistic interaction between the innate and adaptive immunity in trying to combat the virus. The innate immune system can actually release important interferons, interferon type 1, that can have antiviral effects, plus the effects of the natural killer cells in killing infected cells, while the adaptive immune system can produce neutralizing antibodies that can protect against infection, and also the activation of CD8 cells that are specific for killing certain viruses and thus eradicating established infections. So if we review the viral immune response, there is a normal response that most patients with COVID-19 will have. These are the patients who will develop an appropriate response to a viral infection. And this means that there would be enough stimulus to control the immune response as well as stimulate it, and that the immune system can actually clear the virus and cause memory. And this is the ideal scenario. However, there's a certain group of patients who will not present that way, but will present with a dysregulated immune system, wherein there would be increased production of inflammatory cytokines, an enhanced neutrophilic activation, and lymphocyte depletion. And this will enable viral replication and thus what we call viral sepsis. So the T cells seem to be the targets also of the COVID virus. And we see that the T cells can be affected in the sense that the Th1 cells, which are important for antimicrobial effects, especially antiviral effects, can get exhausted. The Th2 system, which is important for trying to control helminths, does not have a main pathologic role, but can also be counter-regulatory to these Th1 mechanisms. And more importantly, is for looking at the T regulatory cells with the anti-inflammatory cytokines that can modulate most of the destructive immune responses. So in patients who have the severe to critical form of COVID disease, there is often an impairment of interferon type 1 production. And this impairment, in contrast to the efficient type of production in mild to moderate COVID disease, will lead to viral persistence. And viral persistence can lead to what we call the cytokine storm, okay, which is an exacerbated inflammation. And the continuous inflammation can lead to multiple organ failure, acute respiratory distress syndrome, and even death. So what is the cytokine storm syndrome? It is a group of severe hyperinflammatory conditions that are part of the spectrum of what we call hemophagocytic lymphohistiocytosis. And we have two forms of this hemophagocytic lymphohistiocytosis, the primary forms, which are basically genetic, but in COVID-19, we have those that occur because of the viral disease. And in other forms of cytokine storm syndromes, you have malignancies and also autoimmune conditions that can cause it. Now, what will differentiate the cytokine storm syndrome from a cytokine release syndrome? This particular terminology is used for adverse effects to monoclonal antibodies. And to further differentiate it from macrophage activation syndrome, this macrophage activation syndrome mostly occurs in the context of rheumatologic disease. So here are the clinical features of the cytokine storm syndrome. It is an uncontrolled and dysfunctional immune response due to continual activation and expansion of lymphocytes and macrophages. This secrete a large amount of pro-inflammatory cytokines, such as mentioned here, and the outcome is an overwhelming systemic inflammation, hemodynamic instability, multiple organ failure, and can be potentially lethal. So early in the course of COVID, around the world, in China, 41 patients with COVID-19 disease were known to have elevated levels of interleukin-1 beta, interferon gamma, interleukin-6, IL-18, and IP-10, plus other cytokines and chemokines, and the levels of which were associated with increased disease severity. So let us review the inflammatory cascade that occurs with SARS-CoV-2 and how it can lead to the cytokine storm. So we have here our virus that can bind to certain receptors called the ACE2 receptors that are found mostly in the lung, the gastrointestinal tract, renal, cardiovascular, or neurologic system. And there is now facilitation of viral endocytosis into the infected cell, whether it be an epithelial or immune cell. Now, these ACE2 receptors rather are downregulated. And when we have downregulation of these ACE2 receptors, there occurs pulmonary injury, fluid electrolyte imbalance, and a form of inflammation that causes disruption of cells and release of inflammatory mediators. And this is what we call pyroptosis. So local inflammation and tissue injury occur. Pyroptosis causes that local tissue destruction due to massive recruitment of macrophages and monocytes and lymphocytes to the injured area. So we see here that one of the cells that can be attacked are the lymphocytes, and that is why there is profound lymphopenia in these patients. There is innate immune cell and Th1 cytokine release in the area, and this particular scenario will lead to activation of the adaptive immune system, hopefully to prime our T and B cells for better control. There is also activation of proteases and reactive oxygen species. So we see here in this slide that interferons are very important for a negative feedback loop towards controlling this condition. So generally, patients should recover from viral infections. And how do they recover? Because the alveolar macrophages can clear up virus that has been neutralized by neutralizing antibodies that are produced also by the immune system. So once this occurs, there is no viral replication or release. And we have further enhancement by your CD8 cells or CD4 cells that can eliminate these infected cells. And thus you have a healthier immune response with minimal inflammation and lung damage. However, for the unfortunate patients who will suffer from COVID-19 cytokine storm, we have here a disruptive response wherein the immune cells do not produce the protective mechanisms. There would just be profound release of cytokines and chemokines that will lead to a systemic cytokine storm, widespread inflammation, and multiple organ damage. So which patients occur, do these things occur? This will happen in patients who may have a genetic predisposition for developing immune dysregulation or hyperinflammation. So the mechanisms of COVID-19 immune inflammatory responses. First, you could have a hyperinflammatory condition. However, to counteract it, you must have the ability, or the immune system must have the ability to control the virus. And one way is through the important effects of interferon 1 or type 1 interferon that would have profound antiviral effects. But patients who are infected with COVID-19 seem to be plagued with the fact that the virus can cause immune evasion, and the interferon 1 will not be sufficient to control it. Then we also have the other activations of immune cells, neutrophils, which can cause further damage. And we also have some dysregulations of immune system, Th1 and Th17, and antibodies. Another important mechanism by which viral persistence can occur and perpetuate the cytokine storm is through the phenomenon called antibody-dependent enhancement. So in this scenario, the virus is now facilitated to enter into the infected cell through an antibody system. And these antibodies will not neutralize the virus, but will cause enhanced replication within the cells and thus prolonged infection and further inflammation. So what are the characteristics of SARS-CoV-2 cytokine storm inflammatory reactions? It occurs in 3 to 5% of adults and 0.6% of children. And severe reactions are more common in the older population because of immune senescence and the downregulation of ACE2 receptors with time. They present with septic shock and multiple organ failure, and oftentimes a hypercoagulable state that is also inflammatory in nature that can lead to disseminated intravascular coagulation. So here are some indicators of COVID-19 cytokine storm. Clinically, they can present with dyspnea or respiratory distress. Through imaging, you would see 50% or greater area of lung injury. And laboratory biomarker abnormalities can indicate the presence of this storm when you have in your CBC lymphopenia or thrombocytopenia, an elevation of the acute phase reactants, elevation of different cytokine levels, and specifically interleukin-6, which seems to be correlated with disease severity and poor prognosis. And there is organ damage in the form of manifestation of different markers of these organs dysfunction. There can be manifestations of coagulation disorders like increased fibrinogen, D-dimer, or the appearance of antiphospholipid antibodies. And the decrease in CD4 and CD8 T lymphocyte counts may occur lower than 50% of the minimal normal range. So this slide tells us that in patients with poor prognosis or in the non-survivors, that the patients may present with very high neutrophil counts and immune depletion of the lymphocytes. You also have high levels of acute phase reactants and cytokines and coagulation markers. You also can have depletion of platelets because of sequestration and eosinopenia that occurs because of stress. So you see here that these particular manifestations can give you an inkling that your patient may be heading towards the cytokine storm. Now, there are some experts who actually question the presence of the cytokine storm in COVID-19 in comparison to bacterial sepsis. So in this slide, they actually mentioned that in bacterial sepsis, there is really a very pronounced and robust cytokine storm with a persistence of interleukin-6 and 8. And you see that the death is quite insidious. Now, part of the inflammatory response, there should be a counter suppression, which is immunosuppression that naturally should occur in any infection. But in bacterial sepsis, this infection or immunosuppression rather would lead to a gradual and progressive lymphopenia, which may cause death. However, in COVID-19, the presentation is quite different in that the cytokine storm manifestations are not as remarkable or not as dramatic. Interleukin-6 increase can occur even at 2 to 3 weeks. And what is more profound in patients with COVID-19 is the immunosuppression or immune paralysis that occurs due to early severe lymphopenia, uncontrolled viremia, that will lead to a florid inpatient death for many of these patients. So just to tell you that in children, the COVID cytokine storm can also manifest in a multisystem inflammatory syndrome. And this has been defined by the CDC lately, that in children who may have fever for more than 24 hours or laboratory evidence of inflammation through elevated biomarkers and evidence of clinically severe illness requiring hospitalization, which can be Kawasaki-like, and multisystem involvement, multisystem organ involvement of 2 or more organs, and no alternative plausible diagnosis with positive and are positive for recurrent or recent SARS-CoV-2 infection or COVID-19 exposure within the 4 weeks prior to onset of symptoms, we must be alerted that these patients, these children, may actually not have Kawasaki disease, but may have a form of cytokine storm syndrome or hyperinflammation that can occur because of COVID-19. So, knowing all this, we now see that the immune response must be modulated for COVID-19 and cytokine storm. And our next speaker will be discussing about the different potential methods or therapeutic agents that can tackle this COVID-19 cytokine storm and give better prognosis for our patients. So in summary, the cytokine storm is proposed to be responsible for the manifestations of COVID-19 disease. An interplay of uncontrolled innate and adaptive immune responses are responsible for this. There are clinical features and biomarker abnormalities that indicate the presence of the cytokine storm, and early recognition of this condition and prompt immunomodulation can possibly decrease morbidity and mortality. So thank you very much for your attention.
So we'll now continue the webinar by talking about the topic of immunomodulation in severe COVID-19. So do we really need to wait for randomized controlled trials? As alluded to by the earlier speaker, this is the time course of COVID-19 infection, and what we're focusing on is a narrow therapeutic window where we think that effective modulation might help and improve patient outcomes. So we're looking at stage 2, which is the pulmonary phase, where patients present with shortness of breath, hypoxemia, and they have abnormal chest imaging in the form of either chest X-ray infiltrates or CT imaging. And the very narrow therapeutic window occurs between stage 1, the pulmonary phase, and stage 3, the hyperinflammation phase, where patients would be predisposed to developing ARDS, SARS shock, or even other forms of systemic inflammatory responses. And when we look at the laboratory and the clinical data in patients who have entered this phase of the hyperimmune response, this is where it's associated with an elevation of the acute inflammatory markers like the CRP, the LDH, the IL-6, very high D-dimer levels, very high ferritin, and perhaps even troponin and the pro-BNP. So if you look at the bottom of the chart, this is where investigators have thought about the possibility of using potential immunomodulatory therapies. And these immunomodulatory therapies are a combination of antiviral drugs, for example, drugs which have been purpose-made for other conditions like remdesivir for Ebola viral diseases. And in fact, if you look at the other immunomodulatory therapies, a lot of the immunomodulatory therapies are drugs which originate from the realm of rheumatology, immunology, and allergy. And some of these drugs are aimed to either reduce the immunosuppression or to downregulate the acute inflammatory response. So you see drugs like corticosteroids, human immunoglobulin, IL-6 inhibitors, IL-2 inhibitors, and even the JAK inhibitors. So the question is, why immunomodulate? So I think the reason why we talk about immunomodulation is because hyperinflammation is something which is potentially dangerous and life-threatening. So this can result in acute lung injury, and if acute lung injury is not arrested in time, patients who survive the episode may go on to develop chronic lung injury, chronic fibrosis, and damage following the ARDS episode or even following the cytokine storm episode. But the big question always is, when is that small therapeutic window where the patient is likely to benefit from immunomodulation, if at all? Where is that very narrow clinical period between the patient developing hypoxemia to the patient developing such severe respiratory distress that the patient needs to be mechanically ventilated? And even after we have identified the reasons for immunomodulation and when to do it, the question is how? Do we use pharmacological therapies, for example, pan-immunosuppressive drugs like corticosteroids, or do we use the very targeted specific therapies like the anti-cytokine therapies? And the next question then is, if an anti-cytokine therapy, then which particular one? Because as you have seen in the earlier talks, it's really a whole slew of cytokines which are upregulated or which may be downregulated. And the question is identifying which is important and the key player, which once you knock out that cytokine, it will help and lead to improvement in the patient's condition. Then what about non-pharmacological treatments? Is there any other way in which you could reduce the risk of hypoxemia? So locally in our ICU, one of the things that we've done is to try and reduce the sequelae and bad outcomes from chronic ARDS is to do this thing called prone awakening, or rather awake proning, where what happens is that when the patient is awake in the general ward, we put the patient prone for hour or 2 hours. And it's believed that by putting the patients in the prone position, not just when they are mechanically ventilated, but even when they are just on supplemental oxygen, it helps to promote the recruitment of alveoli and improve the VQ mismatch. And in doing so, this actually helps to reverse the potential inflammatory infiltrates and the potential inflammatory response that would develop if the patient would progress to develop that ARDS. So when we talk about risk stratifying our patients, and we're talking mostly in the setting of patients, adult patients with COVID infection, we talk about patients being either low risk or high risk. And if you look at the right-hand side of the table, the high-risk factors would include, for example, the age of the patient. So patients who are generally older, in particular those who are 50 years old and above, are at slightly higher risk of developing severe pneumonia, severe COVID infection, and potentially ARDS. If you look at the data on chronic comorbidities from a lot of the various parts of the world, I think everyone has more or less agreed that the usual chronic comorbidities which puts the patients at higher risk include those with chronic lung disease, heart disease, chronic kidney disease, diabetes mellitus, the immunosuppressed patient, in particular patients with chronic kidney disease who are on hemodialysis, or patients with cancers and other malignancies who are on chemotherapy. These would increase the risk of the patient not being able to clear the COVID-19 infection. And I think one of the other things that we found, at least in our centers in Singapore also, is that patients with a higher body mass index of more than 25 are at slightly higher risk of developing bad outcomes, including severe ARDS, requiring a significant period of mechanical ventilation. So the worrisome clinical factors is something which is important to bear in mind on the ground, because when you monitor the patients who may start off as being low risk, who seem to just have a mild acute respiratory infection, if patients start to develop dyspnea or tachypnea, or if the saturation on the pulse oximeter drops to less than 94%, in particular when they get up and when they walk, for example, they walk around the hospital room or they go to the bathroom, then this is a sign that the patients are running into trouble. Or for those who require oxygen therapy. So what we do, at least in Singapore in our general wards, is that when the patients go down the steps of developing worrisome clinical features, that's when we monitor them very closely, not just their clinical parameters, but we also monitor their laboratory results to see whether they are tipping over to develop into fairly severe COVID disease, in particular ARDS. And the other worrisome laboratory results that we've found to be very useful in our setting would be high CRP levels of more than 60, high LDH levels, and the patients who are persistently severely lymphopenic are also those who tend to run into trouble over time. So this is just a picture which shows you macroscopically what happens in the patient with COVID lung. And this lung is a fairly badly damaged lung following ARDS. And if you were to section histologically and look at the lung, you'll be able to identify, for example, the exudative phase of ARDS, as shown in slide here A. In slide B, you have organizing pneumonia as well as microthrombi due to the endocarditis that occurs. And in fact, it's because of the presence of microthrombi found in some of these autopsy studies that has led many investigators to think that really one of the other modalities of treatment that we should be using for some of these patients is not just prophylactic anticoagulation, but perhaps even therapeutic anticoagulation when they are in the intensive care unit. So patients are able to survive the exudative phase of ARDS. They will then go on to develop the proliferative phase, where there's diffuse alveolar damage that you can see here. And then that further progresses to the intermediate phase and the advanced proliferative phase, where what you get is a pretty stiff lung. And the patient who develops respiratory compromise, even if the patient is able to be extubated and subsequently recovers from the COVID-19 infection. And this is just an electron micrograph which shows the viral particles in the infected lung. So we've seen a lot of slides already today on the immunology of ARDS in severe COVID infection, and even the immunology and the mechanisms that are involved in patients who have cytokine storm syndrome. So as you can see, there are lots of cytokines and chemokines question is, among all these cytokines, which particular one is the key player, which if we were to block, it would help to improve the patient's outcome and enable the patient to recover rather than to meet a poor outcome and end up with death. So that's when investigators the world over have thought about what we would call repurposing immunomodulators. So the problem is that if you have a new disease and a new infection, if you would want to come up with, say, a new antiviral therapy or a new immunomodulatory therapy, it would require really a pandemic situation like what's happening now the world over with COVID-19 to help you to come to the discovery of a new drug, a new antiviral drug, or a new immunomodulatory drug. The big question then is that if we already have some of these drugs which are available on the market for various conditions, why don't we repurpose these drugs and use these drugs as potential specific therapies to see whether these could be used as either definitive treatment or adjunctive treatment when treating severe COVID infection. So if you look at A here in the chart, so these are some of the antiviral drugs which have been used in the empirical treatment of COVID-19 infection. And I think probably the best well-known to date in the last month or so is remdesivir, where the ACTT2 trial has shown that there is effectiveness in remdesivir, which is an antiviral therapy initially used in the treatment of Ebola viral disease. And I think fairly fortuitously, investigators have found that this drug appears to work for patients with severe COVID-19 infection, perhaps not preventing them from becoming mechanically ventilated, but at least it does seem to shorten their periods of mechanical ventilation. And there is some promise as well that it will also lead to long-term good outcomes. In terms of other immunomodulatory therapies, I think earlier on in the pandemic, sometime in February, March or so, there was a lot of interest in the use of chloroquine and hydroxychloroquine, a drug which is used very commonly among rheumatologists like us in the treatment of systemic lupus, but it's also used in other rheumatological conditions like rheumatoid arthritis and the milder forms of vasculitis. And how chloroquine, hydroxychloroquine is purported to work in terms of its antiviral effect is through the inhibition of TLR7 and 9 through the innate immune system, through enhancing antigen processing and enhancing regulatory T cell function. Unfortunately, a lot of the clinical trials to date have shown that hydroxychloroquine does not seem to be very effective, either as an immunomodulatory agent or as an antiviral agent. And in fact, many people don't realize that in terms of the antiviral efficacy of chloroquine or hydroxychloroquine, the kind of dosing regimen that we are using in the treatment of severe COVID infection is actually to dose the patient over 1 week. And it's a much higher dose than the daily dose that's used in the immunomodulatory treatment of systemic lupus. In fact, now there are lots of other studies which are looking not so much so now in the definitive treatment for eradicating COVID-19 infection, but in the prophylaxis of close contacts of individuals who may have been infected with COVID-19 infection. So there are a couple of international trials that are ongoing currently. I think one of the other interesting drugs that has garnered a lot of airtime are the anti-IL-6 inhibitors, in particular tocilizumab and some of the other targeted IL-6 receptor inhibitors, including sarilumab and ziltoximab. A lot of the interest from IL-6 inhibition also originated from the role of IL-6 in the cytokine response syndrome, and in particular cytokine response syndrome following So in terms of the repurposing, a lot of interest has been present in the setting of IL-6 inhibitors. And part of the interest which originated from this was because of the role of IL-6 in the cytokine response syndrome, in particular following CAR T cell, chimeric T cell therapy in the setting of oncology. So because of this interest and because of the corollary that in severe COVID infection, you could also end up with cytokine storm. That was why the interest originated in repurposing a lot of these anti Other interests have also originated in the setting of other monoclonal antibodies and also the role of convalescent plasma, meaning to say the recovered COVID-19 infection, you wait for about 4 weeks to 6 weeks following recovery of the patient's infection, and you passively use the patient's antibodies against SARS coronavirus 2 and infuse this into the patient with severe infection, hoping that the patients with the severe infection could develop some form of passive immunity. So if you read the guidelines, there are lots of international guidelines which are now available, talking about potential different types of COVID-19 treatment guidelines which are available. And if you focus at this NIH guideline, the NIH guideline actually does give an update, even up to June, of those immune-based therapies where there is enough evidence to recommend either for or against a particular therapy, versus those therapies where there is no evidence to date to either make a positive or a negative recommendation. So I'll go through some of these from here onwards. So the problem with a lot of these immunomodulatory drugs is that these immunomodulatory drugs are registered for other indications and truly not registered for the indication for the treatment of severe COVID infection. So when we talk about the off-label use of medications in any setting, this refers to the use of licensed medications for indications that have not been approved by national or international regulatory authorities, and hence it is considered as off-label. But an off-label use of medication can be considered to be ethically appropriate, provided there is no proven effective treatment for the condition. It's not possible to initiate clinical trials immediately for the treatment of this novel condition. The patient or his or her legal representative has given informed consent, and after you've started the patient on the medication in an off-label manner, the patient really needs to be monitored very closely for efficacy, adverse effects, and outcomes, be they positive or negative. So I think one of the challenges, in particular in the Asia-Pacific region, is the access to clinical trials. As you know, there are a lot of clinical trials which are available now for various severities of COVID infection. A lot of these started off as PI-initiated trials, mainly in Europe and US, and in those areas where the pandemic was very severe. And some of these trials were then taken up by pharmaceutical companies and developed into worldwide studies. So, for example, the Solidarity trials, which are co-sponsored by WHO and the participating countries, the NIH trials, and the very well-known Recovery UK trials, for which there was good evidence that dexamethasone could be effective. So in our local setting and in many countries as well, each country has set up their own interim treatment guidelines for COVID-19 infection. So this is the one that we use in Singapore, which is a collaboration between the National Center of Infectious Diseases, our hospital, Tomas Hospital, as well as the Chapter of Infectious Diseases in the College of Physicians Academy of Medicine. So as with all treatment guidelines try to give a grading of recommendation and rate it as either A, B, or C, depending on whether it's a strong recommendation, a moderate recommendation, or a C, optional or fairly weak recommendation. And with each recommendation, there is also a level of evidence which is tied to it. So level 1 being based on one or more randomized trials with clinical outcomes and a validated laboratory endpoints. Level 2, one or more well-designed non-randomized trials or observational cohort studies, and in fact, a lot of initial studies on severe COVID-19 infection were based mostly on non-randomized or observational cohort studies. And number 3 being the weakest, that based on expert opinion. So there has been a lot of interest in corticosteroids because in the era when we had the SARS outbreak and the MERS outbreak, corticosteroids were fairly widely used, and that was because during that era there were not many targeted therapies in terms of cytokine therapies, which were available for many of rheumatological, hematological, or oncological diseases. So the data on corticosteroids, the efficacy has been rather controversial, and it has to date been largely based on observational studies with conflicting results, and a lot of it is based on the data from SARS and MERS. problem with SARS and MERS infection is that in that era, corticosteroids appeared to delay the viral clearance and increase the risk of bacterial and fungal superinfection. And because of that, most guidelines did not initially, at the beginning of the pandemic, recommend the routine use of corticosteroids unless clinically indicated. And the problem with corticosteroids is it's also a question of what kind of corticosteroids you use, the dose of the corticosteroids, and the duration, because then these would impact the outcomes, and in particular will also impact the risk of the patients developing secondary infections. So this is just a picture, a cartoon, which shows you the immunological effects of corticosteroids. And glucocorticoids inhibit inflammation by dampening signal transduction downstream of pattern recognition receptors, cytokine receptors, and Fc epsilon receptors. And I think the problem with glucocorticoids also is that it regulates adaptive immunity by inhibiting lymphocyte activation and promoting lymphocyte apoptosis. And the higher the concentration of glucocorticoids that you use, it also inhibits the production of B cells and T cells. So it's always a question of finding what is the ideal glucocorticoid and finding that right dose which does not overly immunosuppress the patient and lead to bad outcomes. So the recovery trial from UK is a large multi-center open-label randomized controlled trial. And the aim of the trial was to assess a range of treatments for patients hospitalized with COVID-19 infection. And it was a very large trial where there were 11,500 patients, of which 2,104 were randomized to receive dexamethasone 6 milligrams orally or intravenously for 10 days. And this regime in the severe patients, the ventilated patients, showed that there was a reduction in the risk of 28-day mortality by 35% in patients requiring ventilator support, with a rate ratio of 0.65 and a fairly good 95% confidence interval of 0.48, 0.88, with a very significant p-value. And it also reduced by 20% in patients receiving oxygen compared to those in the usual care control group. However, it was not shown to be of any benefit in patients who did not require respiratory support. So these, stemming from the interest in dexamethasone, there are many other dexamethasone clinical studies which are now currently running in different parts of the world with different timelines to closing of recruitment. And as you can see, a lot of authors are using not just dexamethasone per se, but they are also comparing dexamethasone in combination with other drugs, for example, with hydroxychloroquine, against a comparator of hydroxychloroquine alone, dexamethasone versus placebo in most of the studies, and dexamethasone versus the usual standard of care in many of the other studies as well. And if you look at the last row, it is not uncommon to see that a lot of interest has always been in other forms of steroids, for example, methylprednisolone, low-dose pulses or hydrocortisone in the intervention arm in patients with ARDS. But if we look at just the ARDS literature alone, it is still open debate now whether corticosteroids work or not. So in COVID-19 infection with ARDS or lung-limited injury or even a cytokine storm syndrome, perhaps the pathophysiology is slightly different from ARDS due to all other causes. So if you look at the NIH panel recommendation for corticosteroids, the recommendation is now that dexamethasone at a dose of 6 milligrams per day for up to 10 days is recommended in patients with COVID-19 infection who are mechanically ventilated with the evidence at A1, and in patients who are not mechanically ventilated but only require supplemental oxygen, then it is not recommended. The panel recommends against the use of dexamethasone in patients with COVID-19 who do not require supplemental oxygen, and partly because a lot of these patients probably just have a mild acute respiratory infection or fairly mild pneumonia, which will self-resolve on its own. So oral corticosteroid therapy that was used prior to COVID-19 diagnosis for any other underlying condition, be it adrenal insufficiency or rheumatological disease, should not be discontinued. And on a case-by-case basis, supplemental or special steroids may be indicated. So I think if you look at a lot of the recommendations that have come out after the recovery study, a lot of the recommendations worldwide are now proposing that corticosteroids can be recommended in certain situations. particular the use of dexamethasone, or where dexamethasone is not available, the equivalent dose of the same of an alternative glucocorticoid like hydrocortisone or methylprednisolone is also, or even prednisolone, oral prednisolone, are also possible alternatives. So the interest in IL-6 was because of the role of IL-6 in both local inflammation as well as in systemic inflammation, as was alluded to by the earlier speakers. So suffice to say that IL-6 is a pleiotropic pro-inflammatory cytokine which is produced by a variety of cell types, including lymphocytes, monocytes, and fibroblasts. And we do know from literature that in severe COVID-19 infections, IL-6 levels are elevated. In fact, at a practical level, you'll find that the IL-6 levels in general do correlate fairly well with CRP levels because CRP production by the liver is driven by IL-6, as can be shown in this cartoon here. But the problem that we have found in our experience with measuring IL-6 levels in the serum and CRP levels is that even patients with fairly mild disease can have fairly high CRP levels during the initial 1 to 2 weeks of an acute infection. But most of the time, the CRP levels peak at about 20s to 30s, and once the lymphopenia reverses itself, the CRPs come down. But the problem is that in the first 1 to 2 weeks of an acute infection, no one really knows which are the patients who will suddenly deteriorate and become hypoxemic versus which are the patients who will just run a natural course, and even if you did nothing, they will just recover on their own. And in our experience, even patients who have fairly poor risk factors, for example, patients with hypertension, patients with chronic kidney disease, patients with heart failure, there are some of them who manage to turn around at that point in time when we were contemplating giving them anti-IL-6 receptor blockers because we thought they were going to deteriorate. So it seems to be a bit of a hit and miss if you talk about the patients in the clinical setting that treat. So IL-6, as you can see, IL-6 inhibition, the signaling is fairly intricately linked to JAK-STAT inhibition and gene transcription as well. And I think it is for this reason that there was subsequently some interest in the role of JAK inhibitors in the pathogenesis of SARS-CoV-2 infection-associated ARDS specifically. So because of this interest, there was an interest in a JAK inhibitor, JAK1/2 inhibitor called baricitinib, which is approved for the clinical indication of moderately severe rheumatoid arthritis. Because there was some interest which appeared to show that JAK inhibition might also have a role in impairing the entry of SARS-CoV-2 by inhibiting the AAK1 and the GAP-mediated endocytosis of the virus through the ACE2 receptor in the pneumocyte. So if you look worldwide, there are a couple of baricitinib JAK inhibitor trials, clinical trials, which are now available. In particular, in Singapore, we now have managed to get access to one of the clinical trials, which combines remdesivir with the JAK inhibitor baricitinib. And some of these trials are still recruiting in a competitive manner. So I think the problem, perhaps to many of the countries worldwide, is a question of whether you will be able to access these trials in time enough. So if you are able to access these trials, then yes, the patients would get access to the drug, in particular to remdesivir, because it's commercially not available in many countries as yet, other than through a clinical trial setting. So if you have no access to these trials, then well, in the severe patients who is really deteriorating in front of you, I think many of us clinicians on the ground would want to think of some form of immunomodulatory therapy rather than just to sit there and wait and watch the patient deteriorate. So interference, as was alluded to earlier on, is an important protective mechanism because interference help our immune system to get rid of the viral infection. So there are three important interferons that we have to bear in mind. Interferons are a highly complex family of cytokines with diverse effects on immune function. And I think the more important one are type 1 interferons in terms of clearing viral infections. So you have interferon alpha, beta, kappa, epsilon. You also have the type 2 interferon, which is a single member interferon gamma, which has both pro-inflammatory and immunomodulatory functions. And the type 3 interferon is a group of interferons which function broadly at anatomic barrier sites and have very unique effects, mainly on hematopoietic cells, most likely the neutrophils. So the type 1 interferon interferon system serves as a very important major line of defense against viruses and microorganisms by promoting both the innate and adaptive immune responses. So it's important because it has both antiviral as well as immunomodulatory effects, and the innate immune system's response to the viral infection initiates an intense but very transient type 1 interferon expression. So this is just a cartoon which shows you what happens when type 1 interferons are released during an acute viral infection. So as you can see, it peaks fairly quickly and then it subsequently drops. And this kind of happens much faster than the rate at which your viral load increases and then it decreases. But nonetheless, what's important is that this tail end of the interferon response is important in the antiviral response. And why this interest in interferon? I think the interest in interferon is because of the potential therapeutic role of interferon beta as an immunomodulatory therapy, in particular in SARS-CoV-2 infection. And as was highlighted earlier on by my previous speakers, the OFF6 and 8 and nucleocapsid proteins of SARS-CoV-2 inhibit type 1 interferon signaling pathway. So as early as March 2020, there were various small clinical trials, observational studies of the use of lopinavir/ritonavir, which is otherwise known as Allergy, used in the routine treatment of HIV infection. And what a lot of investigators did was to use Allergy in adults who were hospitalized with severe COVID infection and combine this together with beta interferon to see whether there was a potential antiviral and immunomodulatory response which could help to improve the outcomes of these patients. And in fact, in Singapore, this is one of the earlier regimes that we use as well. But to date, I think most of the clinical studies have shown that it doesn't seem to be very effective. And it's unknown whether the non-effectiveness, whether it could be due to the delayed enrollment of patients because patients may have had onset of symptoms much earlier, or whether it was due to other reasons. So the median in most of these patients who have been on these therapies were at least 14 days or more from symptom onset. And a lot of the problems that we face in patients with this regime was actually the side effects of Allergy. A lot of patients develop elevated liver enzymes and gastrointestinal side effects. And when you combine beta interferon, you also get the problems with side effects from interferon, fever, flu-like symptoms, for example. However, in May 2020, there was an open-label randomized phase 2 trial of triple therapy from colleagues in Hong Kong, which tried a combination of lopinavir/ritonavir plus ribavirin plus subcutaneous interferon. And this study very elegantly showed a significant reduction in terms of the time to negative nasopharyngeal swab from 7 days in the combination group compared to 12 days in the control group, symptom alleviation, as well as a reduction in the duration of hospital stay. So this was, I think, a fairly interesting study, which seemed to show that, well, there could be a potential role in triple therapy in perhaps certain subsets of patients. So there's still a lot of studies going on. So we talked about hydroxychloroquine, which was made fairly famous by the US president. But the problem with all the hydroxychloroquine trials is that it's not shown to be very effective. Most of the earlier trials were mostly retrospective cohort studies, mostly from New York. Observational studies in patients who were intubated or who were really very unwell. And also open label randomized trials in China and observational studies in France. For example, in patients who were transferred to the ICU. Well, currently in the recovery trial, there was an interim analysis of 1,542 patients who were randomized to hydroxychloroquine versus 3,132 who were randomized to usual care alone. And it was found that there was no significant difference in the primary endpoint in terms of the 28-day mortality. It was 25.7% in the hydroxychloroquine arm versus 23% in the usual standard of care arm, with a hazard ratio of 1.11. And there was no evidence on any beneficial effects of hospitalization or the duration of hospitalization. So I think the jury's out for hydroxychloroquine. Many centers have removed it from their guidelines, including ours. So no longer is it recommended to be used in the treatment of COVID-19 infection with level 2 grade B moderate level of evidence. So convalescent plasma is one of those things again which originated from MERS, SARS-CoV days, where you wait for the patient to recover and then you harvest the antibodies from patients who have seroconverted. I think the problem in convalescent plasma collection is the intense amount of work which is needed to screen patients to collect the convalescent plasma. In fact, a lot of patients, at least in our setting, have been very willing to come forward to volunteer their plasma, and we, our hospital, together with the National Center of Infectious Diseases, have a pool of patients who have been coming forward to donate their plasma. And I think we have given convalescent plasma perhaps to about 2 or 3 severe patients today with fairly variable response. So if you look at the Cochrane analysis, which was done in May 2020, the evidence to date was that based on a rapid review of 8 very small studies in COVID-19 infection, it showed that the effectiveness and safety of convalescent plasma was really quite uncertain. And I think one of the reasons for this is because there are no RCTs, and the review authors found that there were 48 ongoing studies, including 22 RCTs, but none of which have been completed today. So I think convalescent plasma is still used in most sectors as what we would call off-label treatment, or perhaps even experimental therapy. Only when all else fails and when you have no other options, then this is something that you could consider. But it is really it does really take a lot of time in order to ask the patient to come back, collect their plasma, store the plasma, process the plasma. So quite a lot of work. So in summary, I think if you look at most guidelines, of which the NIH recommendations are most representative for immune therapies to date, recommendations to date is a fairly strong recommendation for dexamethasone in patients who are mechanically ventilated, but not in patients who do not require supplemental oxygen. And also in patients who require supplemental oxygen, the level of evidence is slightly weaker. It is something which can be considered because sometimes patients on supplemental oxygen may deteriorate fairly rapidly. Oral corticosteroid that was used prior to the COVID-19 diagnosis for any underlying condition or for stress response can still be continued on a case-by-case basis. The recommendation is against chloroquine or hydroxychloroquine for treatment, except in the setting of a clinical trial. That has always been in every pandemic, a respiratory virus pandemic, an interest in using IVIG. But again, in the setting of COVID-19 infection, there is no evidence that this works at all, other than in the setting, for example, in a patient who is already, say, has got underlying primary immunodeficiency and is already on regular IVIG replacement, then that should be continued. But IVIG treatment per se does not have a role. There's also negative recommendation against the use of interferons, for example, alpha and beta interferon for the treatment of COVID-19, except in the context of a clinical trial. Level of evidence is A3. And for the JAK inhibitors like baricitinib, also there is a recommendation against the routine use, except in the context of a clinical trial. What about the others? So for convalescent plasma IL-1 inhibitors, where there are quite a number of studies in various parts of the world, for example, using anakinra, mainly I think currently still in the setting of case series and retrospective cohort studies which have been reported. So because of the fairly low level of evidence, there is insufficient evidence to recommend at this time for or against this therapy for severe COVID-19 infection. And IL-6 inhibitors, despite all the hype about it, for all the 3 drugs, sarilumab, tocilizumab, clinical trials are currently ongoing, including using combination therapies with remdesivir. Clinical trials comparing IL-6 inhibitors versus IL-1 receptor inhibitors using other add-on modalities like hydroxychloroquine or methotrexate. So until these trials are reported, currently there is really insufficient evidence to recommend these therapies, to recommend for or against using these therapies other than in off-label manner. Thank you.
Okay, first of all, I'd like to thank everyone. I thank Professor Wang, Professor Recto, Professor Tong for the excellent talks. We will be having Professor Latif also talk shortly afterwards, but we'll be recording him later. And so we'll start the questions for all the speakers. I think we've had a very good overview of the different aspects of COVID-19, right from the epidemiology to its clinical manifestations, to its virology, immunology, the cytokine storm, its relation to asthma and allergies, and of course the immunomodulation and the therapies. So it has been a fantastic session. So I will start with a few questions. Now first to Professor Wong. Professor Wong, is there a difference between mild and severe asthma in the comorbidities of COVID? Because there are some publications from UK that talk about severe asthma as a comorbidity.
I think at the present moment, it's still this is an open question that we still don't have a definite answer. And if asthma is really underrepresented in severe asthma, in the severe COVID-19 patient, we still don't know. But at least in the mild case for COVID-19, maybe asthma will also occupy a large portion. But still, at the present moment, it's still we didn't know. We don't have a definite answer.
The other question is like, there are multiple other factors when we think of it. Some, of course, are the mechanistic factors you mentioned, but also the factors that maybe they are staying at home and with the lockdown and the less air pollution, so they are less exposed to the trigger factors, or maybe the asthma exacerbation is less. So do you think that could be one of the factors?
Yes, well, I think you make a very good point, because because we all have the experience that our asthmatic patient were somebody very cautious, particularly during the virus pandemic season, particularly during the winter time or springtime. They will try to avoid to have a social distance with the other person, and they may be isolated. And particularly during this pandemic region, they were especially cautious. But still, we still don't know what is the really truly epidemiology, particularly on the general population, and then what is the really percentage for the non-symptomatic or minor symptom, or even the severe COVID-19 patient. Because at the present moment, we found that all the data coming from the hospitalized COVID-19 patient. So still, we don't know what is the truly incident for asthma in the general population when they have a COVID-19 co-infection.
And what about you showed slides about omalizumab, and so many of these asthmatics may also be on biologics. Are they better protected as compared to the others? Is there some?
Actually, omalizumab about published 2 years ago, a very big study have showed that if they use omalizumab, at some point they can increase their antibodies activity by the increased production for the type 1 interferon alpha in their peripheral mononuclear cell, or even isolated for the plasma cytoid dendritic cell. So it maybe have the benefit, but still we don't. This is a very circumstantial evidence. Say maybe omalizumab still can have some of the protective, but still we don't know what is the true mechanism in SPEAR at the present moment. But at least we can tell that for omalizumab use, they did not increase the incidence for COVID-19 infection.
Okay, thank you very much. I have a question to Professor Recto now. Just what when you talked about the cytokine release syndrome and the massive cytokine storm, you mentioned about the macrophage activating syndrome. So, do you think that their macrophage activation does not play an important role, or are there two types, those that are having the macrophage activation and those that are more T cell?
Well, it's a matter of terminology. So I think basically it's a hyper-inflammatory response that occurs in the three conditions, and it would all depend upon the triggering factor. So if you talk about macrophage activating syndrome, this occurs in the context of an autoimmune condition, something which means chronic inflammation due to autoimmunity. While on the other hand, the cytokine release syndrome is a terminology that occurs, basically the hyperinflammation occurs because of a monoclonal antibody treatment. So it's like an adverse reaction. Now, in the context of COVID-19, it would be more accurate to use the word cytokine storm syndrome because it is like the secondary hemophagohistiocytosis that occurs because of viral infection. So it's really same immunology, but different terminologies because of different trigger factors.
Thank you very much for that excellent answer. Professor Bernard, would you like to ask some more questions to Professor Recto?
Oh, in fact, I had a comment to make because, well, being a rheumatologist, we don't see as much of the macrophage activation syndrome as I think pediatricians tend to see more of, in particular in pediatric rheumatology and in pediatric viral illnesses. So the way that I look at it is that I think in COVID-19 infection, at least in the adults, the kinds of cases that we are at least seeing in Singapore seem to be more a lung-limited kind of acute, adult respiratory distress syndrome and adult acute ARDS. We don't seem to see the kind of cytokine storm syndrome that's reported in the rest of the world, in particular in Europe. I think in adults, it's also a little bit complicated because a lot of the adult patients do tend to come in with a lot of comorbidities in the intensive care unit. And because of their underlying comorbidities, it doesn't take a lot for them to end up with an ICU-associated infection. So that's when things get a little bit complex because then you can't tell what was the original inflammatory response from the original viral infection per se versus when the patient starts to develop a nosocomial infection. In pediatrics, do you think it's slightly different?
Well, there seems to be a little bit of a difference, and why it's so difficult to explain. Like the presentation in children, there's a lot of cutaneous symptoms, like what we see in the MISC, vasculitis, and also some form of DIC. So it's also very rare to have this type of condition in children. So you know, I've seen also adults that, yes, you are right, mostly they die of respiratory problems and secondary infections that may be occurring because of the immunoparalysis that occurs as a second phase of the cytokine storm. But in children, it seems to be a very heightened immune response that is more autoimmune in nature. So yes, I see that difference, but why it's so, we still don't know the answer.
Yeah.
Thank you. Any more questions to Professor Recto? Professor Wang, would you like to ask a question to Professor Recto?
Actually, I think I'd like to ask one question, maybe to Professor Recto, also Professor Song. Is that recently, about last week, there were news coming out and they were reported using the dexamethasone to treat a severe COVID-19 patient, and they found they have more than 30% of the increase of survival rate. What do you think is what is the role for dexamethasone in the cytokine storm, or Professor Song, you would like to comment about using the dexamethasone to treat what is the role in the severe case for COVID-19?
Well, on my end, I've used in our hospital the use of the steroids in several types of steroids, whether methylprednisolone or dexamethasone or prednisone in the initial part of the inflammatory response that occurs with COVID. My question actually also is, I'd like to ask Professor Tong, like what would make dexamethasone special, comparing it to methylprednisolone or to prednisone for that matter, or hydrocortisone, because we know they are all immunosuppressants, they're all steroids. So I'm kind of curious of why dexamethasone would stand out.
Well, I'm afraid to admit that I actually don't know. I'm not sure why specifically they chose dexamethasone in this particular trial. I think if you look at a lot of the ARDS trials, at least in adults, most of the trials have never used dexamethasone before. So I am not sure whether there was any underlying reason why specifically they chose dexamethasone, but it seemed to work. But if you look at the recommendations, they do also say that if you don't have enough of dexamethasone, you can use equivalent of hydrocortisone, prednisolone, or methylprednisolone. But I think at least in our local setting, our intensivists have been very steroid phobic even since the beginning of the pandemic. And I think one of the reasons for that is because of the bad experiences we had during SARS, when we used quite a lot of steroids during that period of time, and the patients didn't have a very good outcome. Because I think in the 2002-2003 era, there was nothing much else to use. So a lot of people were using steroids, and in particular, low doses of methylprednisolone also.
What about the concern about prolonged viral shedding with the use of steroids? Because that's been a controversy as to whether to start it or not.
Yes. So I think a lot of that has again been based on the data from SARS and MERS using steroids. So viral shedding is one important area that we've had to grapple with in our local setting in the control of this pandemic. Because we have found that most times most of our patients would stop shedding around 14 to 21 days. But we have had a small number of patients who have continued to shed even up to 40 to 60 days after the acute infection. And it's probably just shedding a dead viral RNA. So because of this very rather heterogeneous subset of patients, what we've done in Singapore as a policy is that after 21 days of illness, regardless, we discharge the patients from the hospital or any community care facility. Because our local studies have shown that by about 11 days, even if the patients are PCR positive, most of the viral cultures are negative. So if we added on the additional margin of another 2 weeks, up to about 21 days, we think most of these patients are safe enough to go home. So because of the problems with access to having enough supply of PCR reagents, PCR swabs, and things like that, what we've done as a policy is by 21 days we don't swab them anymore, and we just let the individuals go home. But we give them an additional 1 week of leave of absence at home. So they basically have 28 days away, and by the 28th day we think they're safe enough to go back to work. So we have by and large, in certain parts of the country, we have stopped this 2 swabs before you can go home policy.
Thank you very much, Professor Thong. Any questions for anyone? Professor Bernard, would you like to ask some questions?
Well,
I think you were sending questions to ask. Just check.
Yeah, I think some of my other questions were mostly for the immune deficiencies. I think I have asked some of the questions already in our discussion just now on the cytokine storm, as well as asthma. I think asthma, we have addressed some of the questions I had earlier on.
I think there were some questions listed that were probably just sent to you. Just have a look at your message.
Oh, okay. Okay.
Yeah, because I think we did.
Yeah, all right. Yes, okay. I think just now we were talking a little bit about pollution, because we always have this. There's always this interest in pollution, diesel exhaust particles, for instance, in patients with allergic airway diseases. So maybe I could ask Professor Poranka and Chuyao, in terms of the lockdowns that have happened in many parts of the world, do you think this has had any impact at all in terms of bringing down asthma exacerbations because there's less pollution now, with less people, fewer people traveling, people working from home?
Yeah, I could take one aspect of it, and then Professor Wang can answer. Definitely, when we look at the, for example, some of the really polluted cities like Beijing and Delhi, New Delhi, especially in the winter months, of course, I mean, the pollution is so high. And that's the time when the schools are actually closed for several days because there is severe exacerbation of asthma in kids, especially. So, of course, I mean, this would occur in adults too, and the high levels of pollution. There are several news reports that have shown that the strict lockdown, for example, in India, has shown really clear skies in New Delhi, and has also shown that similar kind of phenomenon elsewhere. And there is a paper that was published from the Chinese researchers that actually showed a correlation with less asthma and less maybe severe COVID also due to the pollution. So pollution may play a role both on asthma directly, but also on the severity of COVID. Professor Wang, would you like to?
Yeah, I think this is quite interesting observation and also question, because the spear, when we face the lockdown and the social distancing,
What? Can't hear you. Professor Wang? Can't hear you. Professor Wang?
hello?
Yes,
Can
yes.
you hear me?
Yeah, now we can hear you.
Hello?
Yes, now we can hear you.
Lucy, can you hear me?
Yes, now we can hear you. Now we can hear you. Yes, please speak. We can hear you. Daniela, can you just check on this?
Professor Ruby, I see now two profiles of Professor Wang, both active and on microphone, but I cannot hear him as well. So
We
I
just
don't know.
heard it. I think he cannot hear us.
No, Lucy?
We can hear you.
We can hear you. Now I can hear you now. I just want, okay. I just want to say is that after severe lockdown and also social distancing, it's not just only the exacerbation rate for asthma is decreasing. Even we in Taiwan, we have found out during the so-called enterovirus season and also the influenza season, the cases were also going down. So actually, the human activity and also the air pollution definitely will have a very strong influence on the virus infection. Not just only for asthma or for virus-induced asthma. Even we found an enterovirus infection and also influenza infection in Taiwan during this season. It's all linearly going down. I didn't think that this is because of the general population afraid to go to the hospital. Still, we were open for the general practitioner. They also reported the same phenomenon.
Thank you, Professor Wang. Yeah, I'd like to ask a couple of questions to all of us. You know, I mean, we've seen the difference in the severity of disease in Europe and UK and US as compared to, say, Japan or India. And one of the things that was talked about is the BCG vaccination, you know, that BCG vaccination being given in India and Japan, and also in Iran, maybe at a later stage as compared to US and UK. But today we see that in India also there's a huge number, big rise of patients with COVID. So, I mean, it some time back, because of the lockdown, this was one of the postulations. But do you have any comments on this role of BCG for COVID? So Bernard and Marissa and Jiao, can you all answer one by one?
Okay, I come first. Maybe I'm more easier to answer this, but the easy question and the easy answer. I think we don't know actually. Previously, we thought in the BCG vaccination country, it should be somewhat they will protect for the innate immunity, and also we call the BCG vaccination is will increase for the trained immunity. That is the innate immune cell, they got the memory and somehow have a more protective, more active way to have an innate immune response. But unfortunately, just only Professor Pamanka just mentioned that now in India and even in China still, we did not observe really have a protective effect. So the answer that we don't know actually. Maybe BCG did not have a protective.
Any comments from Professor Tong and Professor Recto? Do you have BCG? Oh yes.
Yes, we have the vaccination in Singapore, but I think initially we had some interest in this, and we were wondering whether there was an impact or not. But I think it's very hard to say. It's very hard to say now, just based on Singapore data alone, because of the changing profile of our current outbreak. So as you know, our current outbreak is more in the migrant workers, in the dormitories, more than in the local population. So even during the initial period, when we had the outbreaks in our local clusters, there didn't really seem to be any significant impact of our vaccination. What about in the Philippines?
Yes, that's just.
Well, theoretically, there is a possibility that there would be an immunomodulatory effect. But we have not really done any studies on this, looking at the differences of those who are vaccinated and not vaccinated. Because in the Philippines, majority of the patients, most Filipinos, are vaccinated at birth. So do we really see a difference? I cannot say, because we still have a rising trend in COVID-19 nowadays.
Thank you very much. That was really very interesting, because it was a big discussion. The other thing that I actually always have been trying to wonder is that even though the outbreak occurred in the Asian region, and even though it's really increasing in many countries, and in some countries it's like going up and down. Like I said, in Japan, we had lower numbers, even going up to 12 and 14 in Tokyo, and then now come up to 100 today. So, but yet the other possibility that people talk about is age, that this is the elderly population is a risk factor for developing COVID. But when we look again at the population in India and Japan, Japan has 70% above 60 years, but India has about 60% less than 35 years. And yet we are finding a large number of patients there. And we're also finding, these days, we're finding it more common in the younger population, but in a milder form. So, I mean, if I would like to hear your opinion or comments on this. So,
Well, in patients who have certain risk factors, like the comorbid diseases, or actually I've read about genetic predispositions to developing severe hyperinflammatory responses. These must be taken into consideration in patients who get infected with COVID-19. So we really can't say, but sometimes we see patients who are very young, like the neonates that can get really severe COVID, but the children in between adulthood or geriatric age, they're actually very presenting with mild symptoms. So seems like the stream of ages have some sort of either an immune immaturity or an immune senescence that could make them predisposed to having dysregulated immune responses. So those are just theories. And we see here that there are very healthy people, very healthy young people who still get it and get it severely. So why is that so? I tend to think about genetics. That has a lot to do with their reactions.
okay, thank you very much. Professor Wang and Professor Tong, any comments?
Yeah, I think genetic is also maybe a factor. The other thing is, actually, when we look up a new disease, we were not familiar with, but still, like a COVID-19 or even in the SARS previous about 70 years ago, we still see a very mild to very severe form. Particular, but the COVID still have a lot of different from the SARS. You can see that during that period, with the majority case was very severe and also got affected all got a symptom. But for the COVID-19 and the SARS-CoV-2 virus infection, we see from the full spectrum from no symptom at all, but still have a virus circulating, and the other end is the very severe response, but that is due to the host immune response, and then that is uncontrolled, and become exhausted, or even to become a hyperreactive. So we face a new situation, and definitely we have a lot of things we have to learn. But one thing is for genetic, it's one of the factors. The other, maybe we have to look up, is any different for the, is any virus variation that causes this kind of aspect? We don't know, actually. Yeah.
Professor Tong?
You have a lot of things to work on, yeah.
Professor Tong?
So initially, at the beginning of the outbreak, one of the theories we had was perhaps it was due to the viral load. So when we looked at all these patterns of the patients with hyperimmune response, what we started to do was we started to report the cycle threshold values for all the nasopharyngeal swabs, the sputum swabs, etc. But after a while, we found that there was no pattern, because initially we thought perhaps the people who get the more severe disease are those who had a fairly massive inoculation of viral exposure during the first 1 to 2 weeks during the incubation period. But subsequently, we didn't find any correlation. But that I think it's probably some genetic factors, some other genetic environmental factors which has altered the host immune response. Because even we've had quite a number of families where you have an elderly couple, both of whom 50s, 60s, and both are infected. But it's really very random as to whether the elder person gets a worse infection or not. Sometimes the elder partner of a couple actually gets a milder disease, and the younger one gets it more severe. Initially, I think we also thought that perhaps being male gender, was some kind of a risk factor and a predisposition, but subsequently also, I think there wasn't any correlation that we saw. So I think it's probably in the genes to some extent.
Thank you very much. The other thing that actually keeps coming up also is probably the diet, because we hear a lot about the importance of vitamin D I mean, vitamin D is being promoted as a form of part of the treatment in many countries, and so of course along with zinc. But the role of vitamin D, I mean, for example, the Japanese diet, for example, has a lot of fish and a lot of source of vitamin D. I mean, would that be a prominent factor? I mean, I won't say the most important factor, but one of the factors that could contribute, that maybe Asian food has more vitamin D as compared to more westernized food? Anybody?
I'm usually a little bit of a skeptic with regards to vitamin D these days, because as rheumatologists and the endocrinologists, we hear a lot of vitamin D being purported in terms of its immune effects on cancers, cardiovascular disease, and all that, over and above osteoporosis. I think the vitamin D is just a small immunomodulatory component, but if you look at all the studies on vitamin D, right, it's all very inconclusive in most conditions outside bone and metabolic bone disease. So I'm a bit of a skeptic for vitamin D.
Professor Rector?
Well, again, vitamin D is a potential immunomodulator. It's kind of popular here in our country, despite having a lot of sunshine. A lot of Filipinos are indoors because of the heat, and they're in air conditioning. So we have a lot of patients with vitamin D deficiencies that are slowly becoming, we are starting to recognize them. Now, some of them are completely asymptomatic, and some do have some symptoms presenting with recurrent infection. So yes, the evidence is quite conflicting. We don't have any definite recommendations, but just looking at risk benefits of giving it as a supplement, some patients still opt to take it, and some doctors still give it, especially if there's evidence of deficiency.
Thank you very much. Professor Wang, do you have any comments?
I think I agree with Professor Song. Maybe a lot of fighting for the nutrition factor is an associate factor. It's not a cause factor. So maybe there were some of the immunodeficient patients, they were easily get infected, and they were also lack of sunshine or something like that. So I really think that a lot of nutrition factor is associated with our clinical scientific finding. So we definitely need a so-called cause and effect study. So if we really found that a supplement for the vitamin D, and then they can prevent against the increase for the antibody activity, then we can maybe we can start to look up what other effect in our during our pandemic area to supplement vitamin D. But at the time that all the nutrition factor or even the environment factor, we have a lot of compounding there, and also this is maybe all associated with the human activity or human try to avoid the risk. So actually, I'm quite skeptical unless we can find a cause effect study report.
Thank you very much. Well, this gives us actually a clue for some research that we can do in our region, actually
Yeah.
looking at, even prospectively, probably looking at the role of vitamin D or BCG vaccination. Even if we can do prospective studies, I think it would be very interesting. So I think not only have we've been able to exchange a lot of information that I think would be beneficial to our membership, and I think we can do more things in the form of also for the lay public. I know that many countries are doing national days, like Philippines will be doing National Day for the patients. And so we also were always happy to collaborate together and support in any way to highlight this or make it more visible. And also, like having patient groups come together from the different countries, have them communicate with each other, because patients supporting patients also is an important way of both psychological aspects as well as for long-term chronic diseases. So with this, I would really like to thank my co-speakers, Professor Wang, Professor Recto, Professor Tong, and Professor Latif, who will be joining us later as part of this panel, and for your time and for not only in preparing such excellent talks, but also for the excellent discussion. And it's pretty late, I know, for everyone, but thank you very much. And I'm sure that together we can do a lot, not just for our countries, but for our region and for our patients and for our specialty. Thank you very much, and wishing you a very good night. And we thank our Secretariat for all the support from both Daniela and Marcel.